Hello, and welcome to Edison TV. My name is Aaron Atkar, and I'm a healthcare analyst here at Edison. We're joined today by another new guest, Dr Tariq Mughal of Mendus. Tariq joined as Chief Medical Officer earlier this year. This interview follows part of a series we're recording with Mendus, focusing on some of the broader themes in which the company is working. Today we're going to learn a bit more about Tariq and the blood cancer space. Tariq, thanks for joining me today.
Well, thank you very much, Aaron. It's very kind of you to invite me for this interview. So I trained in clinical medicine here in London, St. George's Hospital, and then I did my postgraduate training in hematology, medical oncology, and stem cell transplant at the Hammersmith Hospital, Imperial College, and also on the other side of the Atlantic in Denver, Colorado. Much of my early career had been focused on the clinical management of patients with diverse cancers, but in particular hematological malignancies and breast cancer. So I've been fortunate enough to have a fairly broad spectrum of therapies for these patients, ranging from conventional chemotherapy to targeted therapy, precision immunotherapy, cellular therapy, and transplant. And much of that is reflected by the different eras in which I've been practicing medicine, mainly in London, but also in different parts of the U.S., particularly Colorado, and then more recently in Boston, Massachusetts, where I still have a chair in cancer medicine. The early part of my career involving translational research was very much focused on a disease called chronic myeloid leukemia, which is a rare form of chronic leukemia. And we were very fortunate, and it was purely incidental, that we selected this disease, which turned out to be genetically the least complex disease. It is driven by what we call one cancer mutation, which is known as shareable. And in the late 1990s, clinical efforts between different academic centers and industry led to the availability of a targeted therapy, which probably was the first successful targeted therapy in human cancer. And this is known as imatinib. It's a form of what we call tyrosine kinase inhibitors. And this therapy literally overnight changed the treatment outcomes for these patients. For a disease which was uniformly fatal at that time in the late 1990s, we were able to make this into a disease where the majority of the patients, well over 90%, were successfully treated, and they enjoyed a life expectancy not dissimilar from that of the general population. However, from the disease perspective, we've been struggling to get rid of every last cancer cell in these patients, which obviously would be very, very difficult to monitor anyway. So we've realized that the majority of these patients, to enjoy a normal life expectancy, they remain on therapy for long periods of time. And obviously, when you take therapies for long period of time, you subject these patients to toxicity, the chronic toxicity, which is both physical and, of course, financial. And the physical toxicity can be quite devastating in some cases. It impacts their quality of life, and rarely it can also lead to potentially life-threatening side effects, particularly cardiovascular. So many efforts from the early 2000s, when the therapies were first approved for this disease, have been focused on efforts to safely and effectively discontinue these therapies. So patients could essentially lead a normal life and not require to take therapy. And this is known as what we call treatment-free remission, or TFR. This particular concept was introduced, like I said, in the early 2001, 2002, soon after the approval of the first TKI. And the efforts at the Hammersmith were led by the late John Goldman, who was my mentor and remained a mentor for almost 3 decades, went on to become my confidant and a close friend. We lived together for a few years as well in Notting Hill Gate. And he shaped my career. And now, some 3 decades after the successful introduction of therapy, we're beginning to see how we can address the treatment-free remission for the majority of the patients. So that's one aspect. In addition to the chronic myeloid leukemia, I've been involved in a number of other myeloid malignancies, acute myeloid leukemia, myelofibrosis, and some of the other related cancers, and of course, breast cancer. My career up until 2014 was almost exclusively focused on the academic and clinical aspects. And then in 2014, in an effort to try to understand how I can contribute to the society as a whole in trying to improve the medicines, drugs, other therapies which are available to patients who could not be treated with the current therapy. I toyed with the idea of joining the industry in parallel with keeping some academic and clinical duties. And I joined a company called Foundation Medicine, based in the suburbs of Boston. And there I understood about the cancer genomics and a lot of the initial work which led to the successful application of immunotherapies. And this is, now people refer to this as the precision oncology. You could say comprises of targeted therapy and immunotherapies. And learning about the genomics in this particular role, I was able to understand the identification of cancer targets more effectively. And then it increased my enthusiasm to try to understand drug discovery and drug developments better. So it was a natural transition. So after spending almost 5 years with the Foundation Medicine, I joined a biotech in New York called Stemline Therapeutics. And there I learned how to validate the cancer targets appropriately, understand about the drug discoveries and drug development. I led the efforts for the clinical drug development, and this is what I did just prior to joining Mendus. The attraction for Mendus to me was the pedigree of the immunotherapies going back to almost a decade. And they had pioneered how to develop what we call mature dendritic cell vaccine in an effort to target minimal or measurable residual disease, which is a disease which is left behind in patients where all clinical evidence of disease has been treated. And this is probably one of the major reasons why people relapse. So you do the clinical exam and everything is fine. You do the different conventional radiology, imaging, and everything is fine, but the patient then relapses soon after you stop therapy. And this is the disease which is only found in the at a molecular level. So, and it's a massive unmet need. And Mendus has been interested in targeting this particular concept in myeloid malignancies. So they started their efforts in acute myeloid leukemia almost a decade ago, soon after the company was formed. And now they're testing this in the middle to late stage clinical trials in acute myeloid leukemia. So that was one principal attraction. The second attraction was the philosophy which Mendus has, and I thought between the corporate establishment and myself, we had a good fit with my mindset and my background, that we could then look at other unmet needs, beginning with other hematological malignancies, and then also looking at solid tumors, such as ovarian cancer and breast cancer. So one of the things I've been doing in the short period I've been with Mendus is to beef up the clinical development program. And in the acute myeloid leukemia, I have introduced another concept which we will be rolling out as a clinical trial, to try to broaden our spectrum in acute myeloid leukemia. And then side by side, we will also look at the targeting measurable residual disease in patients with chronic myeloid leukemia to optimize what I said earlier in the interview, that is the discontinuing therapy successfully to achieve what is known as treatment-free remission. So, this is these are the areas I'm working on now.
Fantastic. Sounds like you've got quite an extensive background in the blood cancer space, so keen to see how your work at Mendus develops. We're curious to know a little bit more about the current status of the lead program Mendus is conducting, so that's AMR maintenance. And then could you tell us a bit more about the potential to expand? So you touched upon it just there, but what might that look like for Mendus?
Yes, sure. Thank you for that question. So in terms of the status of the current principal Mendus study in acute myeloid leukemia, firstly, let me just take one step back. So this is a study which focuses on all kinds of acute myeloid leukemia, with the exception of what we call M3, which is treated in a different way. So this is newly diagnosed adult patients who received intensive chemotherapy, and then they achieve a clinical remission. And at a molecular level, they may or may not have disease. So when they have that disease, it's called MRD positive, and when they don't have molecular disease, it's MRD negative. So we wanted to look at both subpopulation to see what the Mendus lead therapy, which is known as vididencel, actually offers to these patients. So this is a good design. It's a randomized study where half of the patients receive the vididencel with the conventional therapy for maintenance or consolidation, as it should be called correctly, and that is azacitidine. And then the control arm, they just receive the chemotherapy called azacitidine. And right now, as we speak, we have 8 patients who have been accrued into this phase 2b study. And the ambition is to try to recruit 40 patients in the first part of the study, and then make it into a larger international study where we will test about 100 patients. And if the results are robust enough and the safety, which comes first and foremost, is demonstrated, then we could transit this to a registration trial, and then apply for regulatory approval. In terms of what is coming next, so the second AML trial is going to look at the less intensive induction therapy after the diagnosis of AML, and this involves two targeted therapies, venetoclax and azacitidine combined together, and this less intensive regimen usually results in success in about 65-70% of the patients. So our plan would be to give patients 2 or 3 cycles of this, achieve complete remission, and then whether they have molecular residual disease or not, offer them vididencel with these 2 targeted agents. So this way, when these 2 trials are running side by side, we will cover the full spectrum of AML. And then the third trial will be looking at those patients with chronic myeloid leukemia who are struggling to achieve TFR or treatment-free remission. And so we would like to consider adding vididencel to the tyrosine kinase inhibitor, whichever. Right now we have 6 generations of tyrosine kinase inhibitors now. So out of these 6, generation, the first two generations, which comprises of 4 different agents, have already been approved for first line. So people have a lot of choices. So we will allow the treating physician to select any tyrosine kinase inhibitor and add the vididencel to see if we can achieve treatment-free remission in patients who are struggling. And then subsequently, if the safety of the vaccine has been established and there is a robust enough efficacy, we will then test it on the other side of the coin for the treatment-free remission. Because when you achieve it, you want to maintain it in a sustainable way. And right now, we know half of the patients are going to lose their treatment-free remission, and then they need to go back on therapy. So we will do a randomized study where half of the patients will get vididencel only, and then the other half will get nothing and we'll observe them.
Fantastic, Tariq. That's very insightful. Thank you.
Thank you very much.
If our audience would like to learn more about Mendus, please refer to the Edison website where we've got our research freely accessible, or look at the Mendus website. Tariq, thanks again for joining me today.
Thank you. I appreciate it.
It's been a pleasure.